Hello, everyone. Welcome to Practical Talks for Family Docs, the College of Family Physicians of Canada's live clinical webinar series. My name is Samantha Moe, and I'll be your host and one of the presenters for today. Our talk today is entitled At a Loss for Weight Loss, Scaling Down the Evidence for Primary Care. And our goal is to discuss some of the weight loss strategies and the evidence behind them that can be recommended to patients in primary care. First, I'm going to take a moment to read the Statement of Acknowledgement of Traditional Land. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The CFPC recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The CFPC respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. The CFPC shares the shock and grief caused by the tragic discovery of the remains of the 215 children at the Kamloops Residential School. We would like to start today's event with a moment of silence to reflect on the tragedy for the children taken away and the families left behind. We are presenting on YouTube today. Feel free to use the chat window to say hello to colleagues and submit your questions to us, which we'll address at the end of the webinar. You will need to log into Google or YouTube or to your YouTube account. If you cannot see the chat window, you may be in full screen mode. If you're watching this as a live webcast, it is eligible for 1 MainPro Plus credit. In order to claim your credit, you will need to complete a short survey that will be posted in the chat, and we ask you to complete it by Friday. I'm very pleased to be presenting today with my team here at CFPC. I'm going to introduce them, ask them to say hello, and review their conflicts of interest. We are all part of the clinical evidence expert team with the CFPC and also members of PEER, which is an EBM research group with members across Canada. First of all, I'd like to introduce Adrienne Lindblad, who is our clinical evidence expert lead at the CFPC, an associate clinical professor in family medicine at the University of Alberta, and a pharmacist. Adrienne, can you say hello and review your conflicts?
Sure, thanks, Sam. Hi, everyone. So in addition to my work with the CFPC, I am a casual pharmacist with Alberta Health Services at our local hospital, and I have received speaker's honorarium from a number of nonprofit sources like the Alberta College of Family Physicians, the Alberta Pharmacists Association, and the North of 44 Primary Care Symposium.
Thanks, Adrienne. Danielle Perry is a registered nurse. She recently completed her master's in epidemiology from the University of Alberta. Hi, Danielle.
Hey everyone. So I, as well as Adrienne, have received speaker's honorarium from various nonprofits, including the Alberta College of Family Physicians. And I also work for Correctional Services of Canada as a correctional nurse.
Betsy Thomas is a pharmacist who worked in the community for 20 years before joining the PEER team 3 years ago. Hi, Betsy.
Good morning, Sam from Edmonton. It's gloomy here today, but I don't have any conflicts to declare, but I do have a side gig with Alberta Health Services here in Edmonton as a casual COVID immunizer.
Great, thank you. And Joey Ton is a pharmacist and the new manager of our program here at the CFPC. Joey's clinical experience is largely in the community care setting. And Joey, I'll turn it to you.
Thanks, Sam. And for myself, just speaker honorariums from ACFP, but no other conflicts from that. Thanks.
Great, thank you. This program does not receive financial or in-kind support. So with that, I'm going to get started. Our learning objectives for today. By the end of this presentation, the participants will be able to describe the evidence for non-pharmacological interventions for weight loss. We're going to be focusing on exercise, diet, water, and motivational interviewing. You'll be able to describe the evidence for pharmacological interventions for weight loss, including supplements, Naltrexone-bupropion, and GLP-1 agonists. And finally, you'll be able to apply these strategies to a patient case. And with that, I'm going to turn it over to Betsy to introduce you to our patient.
Perfect. Thank you, Sam. So let's meet Frank. Frank is a 42-year-old man in your practice, and he's been in your practice for several years. In the past, Frank has not been interested in discussing weight loss. However, today he tells you that one of his good friends had a heart attack recently, and he's now concerned for his own health. At the visit today, his vitals and his blood work were all within normal limits, and his weight today is 100 kilograms. You mentioned to him that weight loss could have a significant impact on his health, and today Frank is actually interested in discussing this further. So we just want to hear from you. For a patient like Frank, what would you recommend as the starting point for him to lose weight? We'd like you to populate the chat with some of your recommendations. And while that's happening, Joey, I'm going to pick on you. In your practice, what did you typically see that patients wanted to try, or what was being recommended to them, kind of as the starting point for weight loss?
Yeah, good question. Yeah, so in the community practice, it's funny, like in January, it's supplement month, as many would call it. So a lot of people would be coming in asking about supplements, maybe asking a little bit about exercise, but actually a lot of medications as well. So that's why it's good we're actually talking about this topic, because it's going to come up a lot in January, but probably too, we're coming into the summer months. Everyone's vacationing and everyone wants to lose weight during these months, right?
I agree with that. January is definitely a trigger month for a lot of people. There's a lot of resolutions that are made, usually around weight loss or getting back to the gym. I typically see that in September as well sometimes, the start of the school year. People are wanting to kind of get back into routine after summer. So we're seeing some physical activity, lifestyle modifications, yes, probably diet, exercise, some tracking. It's a great suggestion. So what we're going to do today is we're going to go over the evidence over some of these interventions that we can try. So Sam, I'm going to turn it over to you to discuss the evidence around exercise, please.
Great, thank you. So what is the impact of exercise on weight loss? So in these studies, they compared exercise versus control, and the control could be different things. So it could be no treatment, no exercise, or it could just be a little bit of education. And in a general population of adult patients who were overweight or obese, they found that there was more weight loss in patients who exercised over those who didn't. So the difference was 1.5 to 2 kilos over 12 months. That was in 2 systematic reviews of 2 to 4 randomized trials, about 300 to 600 patients. In another study in postmenopausal women who were obese, they saw that, again, exercise contributed to more weight loss of 3.5 kilos over control over a year's time. And that was 1 systematic review in 3 randomized controlled trials of about 700 patients. So what kind of exercise was being done in these particular studies? A lot of it was aerobic, so brisk walking, jogging, biking, stair climbing. And in general, exercise was done over 45 to 60 minute period. So the duration was 45 to 60 minutes, 3 to 5 times a week. There are some studies of specific exercise. So again, in a mixed population of overweight and obese patients, aerobic exercise, which is like the walking, the jogging, the stair climbing, resulted in 1.5 to 2 kilos, very similar, over 6 to 12 months in 1 systematic review of 14 trials. And then circuit training was also studied. And just as a reminder, most of us know circuit training is a bunch of exercises repeated within a minute, so 10 to 20 times in 1 minute. And then you go on to another exercise repeated 10 to 20 times, and then you keep moving through these different circuits. And it's more intensive. There was seen to be a little bit more weight loss, so 4 to 5 kilos over 2 to 12 months in 1 systematic review of 9 randomized controlled trials. So that said, the bottom line for exercise is that in a general population of adult patients who are overweight or obese, exercise may decrease weight by 1.5 to 4 kilos over 2 to 12 months. The next slide I'm going to talk about is talking about exercise in the context of dietary changes, because when we talk to patients and we talk about weight loss, it's usually a mixture of, change your diet and do some exercise. And so the first thing I wanted to talk about is what is the impact of dietary changes on weight loss. So these studies were diet versus control, and those diets were predominantly low-fat or low-calorie diets that were studied, and the control group didn't have any dietary modification. And in a general population, we found that if you made these dietary changes, low fat or low diet, you'd have more weight loss by 4.7 kilos, favoring the diet group over 12 months. And that was from one systematic review of 8 trials. And in that same postmenopausal study of women who were obese, there was weight loss of about 6.5 kilos with diet over 3 to 12 months in 5 trials. So overall, diet changes can help with weight loss, and there's the numbers there for you. And as well, we think that diet likely has a bigger impact than exercise. So when we compare diet versus exercise, there is a difference of 3.6 kilos favoring diet over exercise over 3 to 12 months. And that's from one systematic review of 15 trials and over 2,200 patients. So is there an additive benefit if you add exercise to diet? And in fact, there is a modest additive benefit ranging from 0.5 to 2 kilos over 3 to 24 months. And some of these studies also talked about intensity of exercise. So they talked about high intensity versus low intensity. And you can kind of think of it like high intensity is, jogging and doing the treadmill and doing some resistance, whereas low intensity might just be doing the resistance exercise. So that's kind of the difference. And it's interesting because the answer to this is it depends. So if you don't make any dietary changes, then intensity does seem to matter. So more weight loss with high intensity exercise. But if you do make diet changes, that difference doesn't seem to persist. So that's kind of like the Coles Note version of exercise. I'm going to pass the ball to Adrienne to talk to us about fad diets now.
Absolutely. And so thanks for bringing up diets there, Sam. So I love this picture of this woman wearing a dog cone, saying it's the latest trend. It's called the veterinarian diet, because I think this is so similar to how a lot of fad diets start. They start with this great idea. And in all seriousness, we are going to talk about 2 fad diets in particular today. So the first one that we're going to talk about is the ketogenic diet. And so with the ketogenic diet, we wanted to look at the evidence for some of the longer term studies. Most diets will work usually for a couple of months, maybe up to 5 months, and then weight gain typically tends to start after that. So to get a good idea of how well these work, we do need to look at some longer term outcomes. So there's 2 quite relevant systematic reviews of about 12 RCTs between the 2 of them, looking at or following patients for anywhere from 6 months to 2 years. And when we look at these, we found the ketogenic diet compared to a low-fat diet lost about 1 to 2 kilograms more weight than that low-fat diet. There are a lot of dropouts in these studies. The range of dropouts is about 13 to 84% of people who do not complete these studies. And the other thing to notice is that the results are pretty inconsistent. So if you look at the higher quality studies, there doesn't seem to be much of a difference in weight loss between a ketogenic diet and a low-fat diet. Then in 2018, a really interesting little RCT came out of about 600 people, and they followed them for 1 year. Now, this was not a study that marketed itself as a ketogenic diet study, but if you look at the nutritional intake of the group, it was probably ketogenic, and it was compared again to a low-fat, low-calorie diet. It was a very well done study. Overall, again, there was no difference in weight loss. Both groups lost about 5 to 6 kilograms. But what was interesting is they looked at people's genotypes. And so they did this little subset analysis where they looked at your genotype and said, well, you have a genotype, you should do better on a ketogenic diet. And your genotype says you should do better on a low-fat diet. But when they did that, and they actually did the analysis, they found that that type of genotype actually had no impact at all on how much weight you lost. It really didn't matter. The other interesting thing that this study did is they looked at individual weight change. Most studies just report the mean weight loss, which makes sense for a lot of studies. But when you're talking about weight loss, there's a big variability in how each individual does. So this study reported on it. And what they found is that the individual weight change varied. The most weight lost was 30 kilograms. However, some people gained up to 10 kilograms on the study, just highlighting how individualized and how varied weight loss can be with different studies. So the bottom line for the ketogenic diet is really, it's probably very similar to low-fat diet. Patients might lose a little bit more weight at 1 year. The weight loss does tend to peak around 5 months, like it does for most fad diets, but the effect is not sustained, and the weight does tend to slowly regain after that point. Again, that huge variability and looking at patient genotypes really won't help. None of these RCTs have ever looked at mortality or cardiovascular disease when we're looking at our fad diets. So the other fad diet that I want to mention today is the intermittent fasting. And intermittent fasting, we'll just get caught up, there we go, is a little tricky because it's not always defined the same way from person to person or from RCT to RCT. So in a lot of cases, intermittent fasting means you're going to fast for just short periods of time. So what was done in a lot of these studies is they would ask people to reduce their overall caloric intake by 75% per day. So that means if you're normally on a 2,000 kilocalorie per day diet, you would only take 500 kilocalories in. And in this case, it was often for 2 days per week. And then the other 5 days a week, you would just kind of eat whatever you wanted. But this is very varied. Like I said, in some cases, it would be alternate days. So you would fast for a day, eat regular diet for a day, fast for a day, eat a regular diet for a day. Sometimes it would be a week on, week off, all types of different things. It's been studied a lot of different ways. And what intermittent fasting has been compared to is just your standard continuous diet. So reducing caloric intake by about 25% every day, day in, day out, all the time. So we found a systematic review of 9 randomized controlled trials of at least 6 months duration looking at intermittent fasting versus continuous dieting. And again, there really wasn't a difference in weight loss found after about 6 months to 2 years. There were 6 newer RCTs. Most of them found exactly the same. There was one that was a bit of an outlier that made it look like intermittent fasting might do a little bit better. They lost 11 kilograms compared to 3 kilograms in the continuous diet group. But the study wasn't really reliable. It only included study completers, and there was a few other little issues with it as well. So again, the bottom line with this is that although it's inconsistently defined, intermittent fasting and continuous dieting really result in similar weight loss, usually around 5 to 9 kilograms at 6 months to a year. The bottom line for both of these studies is that it's really important for a patient to find a diet that they're interested in, if they want to do a fad diet, and something that they can stick to, because that is one of the biggest problems with these studies is people just can't seem to stick to them. They can be very, very difficult. In this case, discontinuation rates were about 60% in the intermittent fasting versus continuous dieting groups.
All right. So some of this may resonate with some of you. So in the same breath as you're recommending diet and exercise for your patients, you may be telling them, hydrate, drink lots of water, make sure you're upping your water intake. So what's the actual evidence for water for weight loss? So the evidence comes from 2 randomized control trials. The first one enrolling weight-stable adults with no underlying health conditions. So a generally healthy population. About 48 patients followed for 12 weeks and starting weight of 91 kilos. So in this study, they compared a hypocaloric diet, which was defined as about 1,200 to 1,500 calories per day, with the addition of 500 mils of water prior to each meal. So having them drink about a bottle of water 30 minutes before each of their 3 meals for the day. And then they compared that to diet alone. So over 12 weeks, they looked at the change in weight. And what they found was that in the water group, they lost about 2 kilos more compared to diet alone. And this was statistically significant. The key thing with this study, though, is that patients were generally healthy. So it was a primarily middle-aged group. They were very motivated to lose weight. They didn't have any of those common comorbidities that you see in your practice. So the second RCT took note of this, and they actually ran this study to be more pragmatic. So they wanted to ask the question, well, what about your patients that you see every day in your primary care practice? So these were patients with obesity, recruited from general practices. They removed a lot of those exclusion criteria that were laid out in the first trial. And again, they followed them for 12 weeks. In this case, they compared adding 500 mils of water, again, 30 minutes prior to meals versus an attention control. So an attention control in the study meant, let's just imagine that your stomach is full 30 minutes before you're eating and see if that makes a difference. Again, they looked at change in weight over 12 weeks, and they found a statistical significant difference in favor of water. So they lost about 1 kilo more this time. There, we'll get that caught up. And they also measured a 5% change in body weight. So yeah, just one more, Sam. the proportion of patients who lost 5% or more of their body weight at 12 weeks. And they found that with water, about 27% lost that compared to 5% in control for a number needed to treat of about 5. I wanted to pull in a few context studies as well, because not only are you potentially recommending your patients to drink more water, you may be telling them, well, you're drinking a lot of caloric beverages. Maybe they're adding sugar to their coffee. They're drinking a lot of Pepsi, that kind of thing. So what about replacing those with Splenda or stevia or some of those things? So there were a few trials that looked at this. The first one being an equivalence RCT that was asking the question, are diet beverages the same as water? Do they lead to the same amount of weight loss? So again, they looked over 12 weeks and found that the water group lost about 4 kilos compared to 6 kilos with the diet drinks. So in this case, they weren't actually equivalent, and the diet beverages seemed to make the participants lose a bit more weight. This was consistent with the proportion of patients losing 5% or more of their body weight, again, with a number needed to treat of 5 in favor of diet beverages. And then a second study asked the same question again. In this case, they were replacing some of their caloric beverages with water, diet beverages, or attention control. Again, just imagining that their stomach is full. And in this case, all 3 groups lost weight. However, there was no difference at 24 weeks. So just to sum everything up, supplementing standard diet programs or education with additional water intake, so about 1,500 mils per day, may lead to increased weight loss over 12 weeks. And similarly, replacing caloric drinks with water or diet beverages may lead to increased weight loss, again, over 12 weeks. And no adverse events were reported. So let's go back to Frank and talk about his second visit.
Yeah, so just to keep in context, Frank comes back for a second visit after you discuss with him some things like walking, which he's incorporated about 20 minutes a day, replace some of his drinks with water, try that ketogenic diet, couldn't maintain the restrictions, couldn't tolerate it, but did notice there's a positive. His weight's down about 3 kilos from the 100 kilograms before, and he wants to try intermittent fasting. But this is a big question I think a lot of us get with supplements. He says, "Can I add this supplement? I've heard from Dr. Oz or my friend that it works." So really, what's kind of the evidence that kind of comes out here? So I want to throw into the chat. We were going to pick 2 out of the 4 here. Which ones did you want to cover? I've covered 4. There's a ton of others, which I can kind of summarize, but was there any ones the group was interested in listening to? And kind of as we wait for the answers here, I'm going to ask Betsy. Betsy, you've been in the community for a number of years. Is there a supplement that stands out to you?
I think I've had patients wondering about fiber. And wondering how it might help with weight loss, as well as I think there's a buzz around green tea that I've heard, not only in the clinic, but just even amongst friends and people that I know that are interested in weight loss as well. So those would be the 2 that I would probably choose.
Yeah, no, that's it looks like actually it's pretty in line with the chat here. So we got a lot of fiber and looks like green tea slightly edges out. So let's start with green tea, Sam, and then we can kind of end off with fiber. All right, so green tea. So just a quick summary here. What is it? It's an extract from green tea leaves. Back in the day, they'd be grinding up the leaves, putting them into capsules. A lot of side effects because of the caffeine content. So nowadays, it's more so they extract this. They must dilute the green tea, extract it that way, put it into capsules in some way. But the idea is that you lose weight by increasing this person's energy output due to possibly the caffeine, but due to the other characteristics, I say, of green tea extract. Fairly inexpensive, $20 for about 60 capsules, as per Amazon, and it is one of Amazon's bestsellers. So just FYI on that. But what's the evidence? So luckily, we actually have a good base here. The Cochrane Review did do a systematic review, 14 RCTs, 1,500 patients, and the baseline weight is probably maybe lower than what you'd expect in our practices, but 68 to 95 kilos, that range, with a BMI of 24 to 32. A lot of these groups, and a lot of this research was done in Japan, just because I think green tea is a big staple in their diet and in their culture. So it makes sense. A lot of that research came from there. And it came, in terms of the duration, about 3 months there. But they looked at just green tea extract, whether it be in drinks, supplements, teas, and just compared that to control or placebo. And what they found was there's an additional loss on top of placebo of about 1 kilo with the green tea extract. No significant adverse events. People might be wondering, are you going to get those side effects such as, when you drink too much coffee? But none of those side effects actually came through. So maybe the content of those drinks or those extracts wasn't high enough to show a noticeable difference. In terms of additional evidence, another systematic review, a little bit more recent, looked at 22 studies and found that green tea reduced weight by about 2 kilos more than placebo. So nothing, I would say nothing slam dunk out of the park here, but it had decent evidence to support the supplement. Really, the bottom line with green tea is, based on the best evidence I could find, at most 2 kilos with green tea extract over a placebo supplement over 3 months, and no significant adverse events. And something to keep in mind too is that we talk about placebo a lot, and that you have to remember that placebo intervention is an intervention. So it's not green tea compared to doing nothing. So we do think there is some sort of placebo effect going on. It's just that green tea extract is doing a little bit more in the evidence here. And then fiber, Sam, for the second one here. So fiber is a little bit of a complicated one. You're going to see this a lot in your practice because it comes in so many varying ways. You see, Metamucil is a big one we know of. PGX actually is a fiber supplement, and you're going to hear of other things: chitosan, fructans, and essentially all of them do very similar things. They're all soluble fibers, so you can dissolve them. Some of them are by supplement or capsules, and it's supposed to absorb water. It makes you feel fuller, and you'll eat less because of that, lose weight. Varying costs in supplements there. You can kind of see here, this is the $24 for 200 soft gels, and this is the PGX supplement cost here. But you can see the dosages is kind of a little kind of crazy, 3 times a day. Next slide, Sam. But the evidence, I'm just going to cover the psyllium and glucomannan, and I'll cover the other in the summary. But psyllium, Metamucil, to be honest, only 2 RCTs with psyllium. And they didn't actually find any significant change with versus placebo with the supplement. Some things we'd expect if we had patients on Metamucil, flatulence in about a third of patients in one of the RCTs, but no real side effects, but no real effect here. Glucomannan, so that PGX supplement, a lot more evidence, 7 RCTs here, six patients, and all the way up to a year's worth in follow-up with these RCTs. So, but at best here, about a 1 kilo difference over placebo. If we limited it to just those trials that are greater than 3 months, so that's kind of an indicator of, the longer the study goes, the higher quality it goes, you can kind of see that number dropping. And side effects wise, belching, bloating, and some of the things you kind of see with fiber. But I looked at the other ones as well and some of the other RCTs, and to be honest, when you actually summarize it all, no consistent benefit. Some of them kind of work. Some of them actually stayed in this 1 to 2 kilo range. And you're with a lot of supplements in general. I tried looking at as many as I could, and to be honest, this is kind of where it all fell, but 1 to 2 kilo difference over placebo, mediocre evidence. But really, the bottom line with fiber, there's lots of supplements out there. Side effects are pretty limited, and the 2 and glucomannan and psyllium didn't lead to a clinically significant effect. Because 1 to 2 kilos, if a patient is 100 kilograms, that might not be significant to them. That's kind of the bottom line. It might be statistically significant, but not clinically. And that's kind of that brings me into the summary here to kind of wrap up. Just kind of continuing what I said before. patients are going to come in with a bottle of something, could be anything, and they're going to point to some study. You're going to hear it on the news. If you look at the best evidence with many of the supplements, they're all mediocre. Even the ones I covered, they're RCTs, but they're mediocre RCTs. They weren't the highest quality. And to be honest, we're probably not going to get much better. Lately, supplement companies are getting smart to study possibly a dietary change. They're being followed up more. So, in that essence of being in a study, you're probably going to be on your better behavior than just in normal life, right? So you're probably going to see better results in these trials. And you can kind of see here, it wasn't even that great at 1 to 2 kilo difference. But at the end of the day, no significant harms. And it's probably just going to be down to this shared decision making with your patients.
All right. Well, I am going to cover motivational interviewing. So this might be something that you've done for your patient. There is a ton of evidence in smoking cessation, alcohol use disorder. Not a ton for weight loss, but we do have evidence from 1 systematic review and 4 randomized control trials. The systematic review included 11 trials, just over 3,600 participants, baseline BMI ranging from 27 to 38. The problem came in with how the interviews were conducted and what it ranged in. So the session duration and frequency ranged from 50 to 300 minutes and from 1 session to unlimited number. So literally just you could continue going to these interviews forever. The delivery method was telephone or in person. And in these trials, the delivery person were either nurses, counselors, psychologists, or dietitians in this 1 systematic review. And in about half of the included studies, motivational interviewing was offered in conjunction with this behavioral weight management program. So it was like including these interviews on top of it. So they did look at change in body weight from 8 randomized control trials following patients for 4 to 18 months and found a mean difference of about 1.5 kilos. So a small change over placebo. The problem is we don't really know where patients started and trying to quantify that because of the differences in how they were conducted is challenging. So I'll focus more on the randomized control trials. So the first one, these were in a primary care population with at least 1 cardiovascular risk factor. The interesting thing is that these weren't patients that were overweight or obese as the inclusion criteria. However, at baseline, 99% of them were overweight or obese. So it was essentially that population. They offered motivational interviewing for 6 months, and then they followed them up at 18 months. They compared giving standard information with motivational interviewing, so 5 in-person sessions by a physical activity specialist and dietitian, to standard information alone. So you can see along this trajectory. So on the left-hand side, that's baseline, then at 6 months in the middle, followed by 18 months. And really you can see just from this little diagram that there's really no change. They might've lost a little tiny bit at 6 months, but then their weight was right back up at 18 months. Bottom line from this study is that there was no statistical differences between groups at either time points. So moving on to this, and some key things to note about this study. It was very pragmatic, which is often a really great thing. However, in this case, participants could only access counselors during 2 4-hour windows per week, which led to them only attending 2 out of 5 sessions. The loss to follow-up was high at 37%. And what's interesting is that often when motivational interviewing is done in practice, we think about this stage of change model. So are patients moving towards action, and are they taking their plans for change and putting them into practice and actually doing it? And in this case, they didn't. So they started and remained at a stage 3 or preparing for change throughout the trial. They never moved towards an action stage. So this really correlates well with the no change in their weight. So the second RCT, again, these were adults with a high risk of cardiovascular disease. They provided motivational interviewing for 12 months with a 24-month follow-up. And it was a 3-arm trial. So they compared motivational interviewing in 2 settings, group or individual, compared to usual care. So they looked at 12-month and 24-month outcomes. You can see here that their baseline starting weight was a little bit lower than the last. And essentially at 12 months, both the individual or group motivational interviewing participants lost about 0.5 kilos more. However, there was no difference between individual and group motivational interviewing, and no difference at 24 months. It's important to note too that the study set the minimal clinically important difference in the study at 1.25 kilos. So they were nowhere close to even meeting this MCID with that 0.5 kilo. The third RCT, these were women with type 2 diabetes and a starting BMI of 27 to 50, and they followed them for 18 months. So they compared motivational interviewing, again, in person, 5 sessions, combined with this behavioral weight program to the program alone. And the focus in the study was weight loss at 6 months, followed by weight maintenance at 12 and 24 months. So you can see that the weight doesn't really change at 12 and 24 months, which was the purpose of the study. However, at 6 months, significantly more patients lost weight with motivational interviewing compared to the program alone. So 4.7 kilos versus 3.1. And all points were significant in favor of motivational interviewing. So this study was promising. So from this study came the fourth trial. They said, okay, well, this works well. What about if we just convert this all to online? However, when that happened, there was no difference in outcomes between groups. So unfortunately, that didn't work. So what's the bottom line for motivational interviewing? So motivational interviewing may lead to small reductions, so about 0.5 to 1.5 kilos in weight over 6 to 12 months. However, weight loss is likely not maintained following cessation of interviews. In-person interviews in combination with weight loss treatment programs are likely the most effective. So let's go back to Frank. Go ahead, Betsy.
Okay, thank you. So Frank's back in your office. It's been 4 months since you've seen him, and today his weight has not changed from his previous visit. So he's still at 97 kilograms. And so he has heard about a new weight loss drug and wants to know more about his options. So we're going to look at a couple of options for medication. So the first one is the Naltrexone-bupropion, which is marketed under the brand name of Contrave. So there's some questions sometimes about how these medications work. We would try to focus more on how, if they work and what the outcomes are. But the thought is that both components of this medication reduces cravings and appetite. Bupropion by increasing norepinephrine and dopamine, and naltrexone by blocking opioid receptors. So there was a systematic review that was done that included 4 randomized control trials. And these 4 trials were the mainstay trials for naltrexone-bupropion, because there's other systematic reviews, but they're all reporting on the same trials, maybe just looking at different subgroups or different outcomes. So this particular trial included the 4, and the numbers were just under 4,000 patients, and about 82% of patients were female. And they looked at, they followed these patients for just over a year, so 56 weeks, and their baseline weight was about 100 kilograms. So to be included in the trial, participants were either obese with a BMI of over at least 30 or overweight with at least one comorbidity, and that comorbidity was either dyslipidemia or hypertension. One of the 4 trials included overweight patients with diabetes who were only on oral medications. So they were excluded if they were on insulin or GLP-1s. And another trial included patients who were given intense behavioral modification in both arms, and the intervention was to add the naltrexone-bupropion to one arm. So what did they look at? So this particular systematic review looked at naltrexone-bupropion at the maximum dose of 32 milligrams over 360 milligrams. And this dose was titrated up over several weeks versus placebo. And both arms were given or encouraged to make some lifestyle changes. So that included either having a 500 calorie deficit in their daily diet. All trials recommended some type of exercise. In some of them it was non-specified. Others they said for patients to be walking. And another one said patients should try moderate exercise every week. And everybody received behavioral modification of some sort. So what were the outcomes at 56 weeks? So the primary outcome was at least a 5% weight loss, and 53% of patients who were on naltrexone-bupropion achieved that versus 21% in placebo, with a fairly impressive numbers needed to treat of 4. A 10% weight loss was also significant, so it was about 20% more of patients on naltrexone-bupropion over placebo, with the numbers needed to treat of 5. And when we look at weight loss, the actual weight loss, there was 2 trials that reported. The intervention group lost about 6 kilos and the placebo group lost about 1, for a difference about 5 kilos. And this was again at 1 year, or 56 weeks. So whenever we're looking at medications, we want to look at harms as well, not just the benefits. So these little figures made me laugh, first of all, when I found them on the web, but 2 of them were associated with a website that was talking about how bad the side effects of Naltrexone-bupropion was, so that you should buy their dietary supplement instead. So let's go into the adverse events. So the first one is withdrawals due to adverse events. So this is correlated with tolerability of the medication. So 29% of patients on Naltrexone-bupropion had to withdraw due to an adverse event, compared to 13% in placebo, with the numbers needed to harm of 7. When we look at which adverse events were statistically significant, there was quite a few. These are a few of them, few of the main ones. The first one and the most significant one is nausea. 31% of patients who are taking the medication do experience nausea, compared to 7%, with the numbers needed to harm of 5. Typically, the nausea is classified as mild to moderate, and it occurs when dose titration is happening, particularly in week 1. And it typically ranges from about 9 or lasts about 9 to 14 days. Other adverse events included constipation, headache, vomiting, which kind of went hand in hand with the nausea, dizziness, and dry mouth. There were some limitations to the 4 randomized control trials. They were all industry funded. So that definitely does introduce a bias into, or possibly introduces bias into the results. And as we typically see with weight loss trials, there is a high attrition rate. So this was no exception in these trials. There was about a 45% rate of patients who were dropping out of the trials. And this medication is not cheap. It's about $275 per month, and that does not include any dispensing fees. So this could definitely be a barrier for patients if they don't have a drug plan that covers weight loss medications. So bottom line, over 56 weeks, 53% of patients taking Naltrexone-bupropion achieved at least a 5% loss in body weight, compared to 21% in placebo patients, with the numbers needed to treat of 4. But withdrawals were higher, 29% versus 13%, with the numbers needed to harm of 7. Adrienne, do you want to take us through GLP-1 agonists?
Absolutely. We'll continue on with the meds. And because I love this screenshot, this is from a Dr. Oz episode a few months ago, where he claimed that the diabetes drug could be a game changer for weight loss. And I love it because he's holding a cinder creek block, and it's a really strong visual. And I'll talk about the evidence and what that means as we go through this here. So when we go on to the GLP-1s, the first one we're going to talk about is semaglutide. So we have 4 industry-sponsored randomized controlled trials looking at semaglutide specifically for weight loss. And in these studies, they used a dose that you're probably not very familiar with. They used 2.4 milligrams sub-Q weekly, in addition to lifestyle changes. And they studied this drug both in people who had a history of diabetes and in those who didn't. And after about 68 weeks, the average weight loss with semaglutide was about 10 to 15% of body weight, compared to 2 to 3% of placebo. And what was interesting is the proportion who lost over 5% of their body weight was 70 to 80% of people on the drug, compared to 30% on placebo. That's a number needed to treat of 2. They also looked at people who lost over 10% of their body weight. Again, it was over half of people, 50 to 70% of people lost over 10% of their body weight. I saw a comment in the chat earlier just asking about this 5% body weight. And a 5% body weight is usually considered clinically significant for most people who are overweight. And someone who is really significantly obese with a BMI of like 46, 48, kind of in that range, you want to see something higher, maybe a 17%, but 5% is a good minimal clinical important difference for people in this weight gain of, or weight, pardon me, of about 100 kilograms. And this 10 to 15% body weight that I said, so I mentioned Dr. Oz holding that cinder creek block. So if you weighed 100 kilograms and you lost 15%, that is about the same weight of a cinder creek block. So that's kind of a little visual of how you can remember that. Now, I mentioned this 2.4 milligrams might be a little high compared to what you've seen before, but they have done a dose comparison study comparing a 2.4 milligram dose to a 1 milligram dose. And they did see that you do get more weight loss with the higher dose. It was about 10% for the higher dose compared to 7% for the 1 milligram dose. And they also did something interesting. They did a withdrawal randomized controlled trial. So what they did is they gave everybody in this study 20 weeks of the 2.4 milligram of semaglutide. And then after those 20 weeks were over, they randomized them to either continue on with the medication or to stop it. After 48 weeks of this, the people who were randomized to stop semaglutide regained weight. So they had about a 7% of their body weight was regained if they had stopped it. Whereas the people who continued it continued to lose another 7 or 8%. So this is fairly similar. What we see, Betsy kind of commented on this before, is that once you stop the medication, you do start to see the weight gain come back. One of the problems with the GLP-1s, of course, is tolerability. So in these studies, using that high dose of semaglutide, 75% of people had a GI side effect, usually nausea, compared to about half on placebo for a number needed to harm of 3. But what's different with these is that it was often temporary and usually fairly mild, in these studies anyway. And a lot of people did not stop the medication due to side effects. So only about 7% of people on the drug stopped due to side effects. That compares to, I think it was 30% with the Contrave studies that Betsy was mentioning. And there are some problems with cholelithiasis as well, with a number needed to harm of 71. So that's what we saw for semaglutide. But it is not the only medication that's been studied from this class. Liraglutide, of course, has been studied as well. So we had, again, 2 large industry-sponsored randomized controlled trials, similar patients in terms of weight, baseline weight. They did lose about 3 to 5% of their weight at 1 year. And similar to what we saw with semaglutide, about 2/3 of patients lost at least 5% of their body weight. Again, a number needed to treat of 3. And about 1/3 lost over 10%. Similar to semaglutide, again, once you stop the medication, the weight does tend to come back. And withdrawals for side effects were similar. About 10% of people actually had to stop, usually again due to nausea and other GI side effects. Now, it's kind of interesting. You're probably wondering which one is better, semaglutide or liraglutide. And there is a study, there is an RCT comparing the two. Of course, keep in mind, this was sponsored by the manufacturer of semaglutide. But what they found is that weight loss was about 6 to 14% of body weight with semaglutide compared to 8% of liraglutide. And the reason there's that range is because they had the different doses of semaglutide in that study. So that high dose, that 2.4 milligrams, are the ones who lost 14% compared to the lower dose. So they might be fairly similar, but it depends a lot in terms of how you dose the two. So what's kind of our bottom line with the GLP-1s? Well, I think both semaglutide and liraglutide are effective for weight loss. With the injectable semaglutide, mean weight loss was anywhere from about 3 to 15%. It does appear to be dose dependent. And about 70% of people will lose at least 5% of their body weight over the course of a year and a half. Semaglutide might be slightly better than liraglutide at the higher doses. Again, remember who paid for the study. But I gave an example there. If someone weighs 220 pounds, their final weights will be about 190 versus 200 pounds at best with that range. Both of the drugs do require dose titration for tolerability, and about 3/4 of them will have some type of side effect, but only about 10% stop. So if they can handle it, if you titrate the dose slowly, the nausea will go away with time. So cost and availability could definitely limit use for these. The cost of these medications, if you've used them in practice, you know they are not cheap. We're looking at maybe $400 or $500 a month. The other problem with semaglutide right now is its availability. So I mentioned that dose of 2.4 milligrams. Right now you get semaglutide in a pre-filled pen, and you can really only give doses of 0.25 milligrams, 0.5 milligrams, or 1 milligram. There have been some obesity clinics that have used the higher doses. I'd love to see in the chat if any of you have seen it or used it. And they're telling people to count clicks and things on the pens, but it's getting pretty complicated. It's not something I would recommend for most patients. But because of all the work that the company's been doing with these studies in semaglutide, I would expect that they'll have some other product availability in the near future.
Great. Thanks, Adrienne. Okay, so back to me. We're just going to wrap up with our case of Frank. So 1 month later, Frank continues to walk 3 to 4 times per week. So he's getting his exercise in and has been occasionally following the intermittent fasting diet, although he does have occasional lapses. He recently started liraglutide 3 milligrams sub-Q daily, and he is having some nausea, but he is willing to continue to see if it improves. So you plan to follow up with Frank in 3 months. So I'm just going to go over our summary slide. If you have questions for us, please feel free to put them in the chat and we'll address them. In summary, in terms of addressing weight loss in primary care, a lot of this is stuff we know, and the evidence that we reviewed is as follows. Encourage patients to find a diet they can stick with. Advise patients to do some physical activity 3 to 5 times per week for 30 to 60 minutes. And whatever exercise they would like to do is probably the best one for them to try and stick with. Increase water intake. And as we talked about, naltrexone-bupropion can reduce weight by 5 to 10% over a year, while the GLP-1 agonist can reduce weight by 10 to 15% over 1 year. So I'm going to turn it over to Joey and see what kind of questions we got in the chat.
Yeah, thanks, Sam. So this might be a question to the group, but there is a question on, did we see anything on diaries, like maybe diet diaries or calorie counting?
Mm-mm.
No, I haven't seen anything. I haven't looked those specifically for that. I know some people do like it when they are trying to reduce their calories. Some people like that type of thing. Some people hate it. That's kind of basically, I'm saying that just on experience more than anything else. But some people do like it to actually, it forces them to pay attention to what they're eating, because some people don't think about it very much.
I think it's interesting too, like in the water studies, oftentimes they had a diet going on in the background too, and then they're just adding water. And oftentimes in that case, they were required to like record everything that they were eating. And both groups lost a significant amount of weight. So like that's not evidence specifically for that, but it was interesting to see that they required it.
Yeah, thank you. Another question was asking, we talk about those clinically significant findings of 5% or 10% for weight loss. What about other heart outcomes like cardiovascular? Were there any of that with the drug trial specifically?
Joey, actually, with the naltrexone-bupropion trials, there was actually a randomized control trial of almost 9,000 patients. In that particular trial, they were actually looking to see if the drug caused cardiovascular events. So they were looking for MACE in those trials. Unfortunately, this was a really interesting trial to read. When they were at the 25% analysis, one of the drug companies released that information because it was looking like naltrexone-bupropion was actually preventing MACE events. So it was, the hazard ratio, I believe, was 0.59. So after that happened, it was decided the trial should be stopped because it was no longer, because that information wasn't confidential anymore, and it could actually bias the results of the trial. So they were actually able to, at that time, collect about 50% of the analysis for events, and they found that the hazard ratio was actually becoming closer to the same as placebo. So we're still like uncertain about the cardiovascular impact of that particular medication, and it was really unfortunate that the trial was stopped because they had a decent amount of people and they were looking for the right things. So really, it's kind of unknown right now, but it was looking like they were going to be about similar.
Okay, thanks, Betsy. There's a question, again, another medication one. Was there any trials looking at the combination of semaglutide and contrary? I guess Betsy or Adrian, this one. Did you guys come across anything?
No, I never saw anything about the combination. I just wanted to add a comment about the cardiovascular benefits of the GLP-1s. So they didn't look at that with the obesity studies, but of course they have looked at the effects of GLP-1s in diabetes, and they do reduce cardiovascular disease and all-cause mortality in that population. So there's definitely some promising stuff there.
Great. In terms of, I guess, again, maybe a question for Betsy. Starting someone on naltrexone-bupropion and they're already on an antidepressant, did you see anything in regards to that combination?
In the trials, if patients had severe depression, they were excluded. However, when we looked at the trials, depression, it did seem like it was lower, or it was actually not statistically significant between the two groups, but they were not on other antidepressants, so I can't really comment on adding. I think you would just have to monitor your patients if you thought that was a good option for them, that you would have to monitor them because, as you know, bupropion has that potential increase for suicidal ideation. This did not come across in the randomized control trials in any of the 4. However, it's still part of the product monograph, so that's something to consider as well.
Great. In terms of the summary slide, so yeah, Brian, thanks, Brian. You it's there as well. We're gonna have the slides as a handout afterwards. It'll be available on our website. So the other supplements, the evidence it's covered there if you're interested. And I guess this is probably another question for Adrian. In terms of GLP-1s, you talk about, so let's say you have a patient who already has gallstones. What was your take on, GLP-1 in those patients?
Yeah, so hopefully they don't have active gallstones. I don't think I would use it in those patients. They have enough going on as it is, but a history of it. I think it's going to be at a bit of a risk benefit that you're going to have a conversation with that patient and see what their thoughts are in terms of are they willing to accept that risk. I think a lot of weight loss treatments can cause gallstones. So it's something to keep in mind. Is it an option for them? Maybe. Depends on how many they've had, how severe of an attack it's been. For a lot of people, that's going to be a hard no. They don't ever want to go through that again. And that's totally reasonable as well.
It's interesting because in the Naltrexone-bupropion trials as well, it was associated with a significant amount of weight loss. And so that's something to consider too, that there might be at a higher risk if they're losing quite a bit of weight to get a gallstone. But it was not statistically different from placebo either for the Naltrexone-bupropion versus placebo.
I'd probably be a lot more concerned if someone had a history of pancreatitis. That seems to be a side effect. I didn't talk about it too much here because it's really not very well reported in these studies in particular. So in these studies, you had maybe 3 patients in one study had pancreatitis, but that's an issue that it's really not very well studied in these studies. And I think we know the final answer on the risks of pancreatitis or pancreatic cancer with these drugs.
Thank you. I guess I know a question for me too. Cost always comes up in terms of coverage. Like, do you know the status on the coverage of these for weight loss specifically? I know actually I'm not familiar with semaglutide, but yeah, any comments on that?
Semaglutide, I would say probably for sure is not covered because right now we don't have an easy way to even administer it. So I kind of mentioned that the pens don't provide for it, and I know some clinics are telling people to count clicks while they're turning a pen, but you're talking about like over 30 clicks that they're trying to count, and it's very, very complicated. So that would not be covered. I can't remember liraglutide. I want to say it is not covered for weight loss, but I'm not sure. I don't know if anyone else on my panels or if anyone has any, if they could type in a comment if you're familiar with it. I didn't think it was, but
I think based on what I know, I in Alberta at least, I know some docs are writing it. They're using under like the label of with diabetes rather than the indication of weight loss. That they're getting coverage that way. I don't know how it is with other provinces, but with contrary, is that no province is covering that right now, or is it?
I haven't experienced that. It doesn't seem like it's covered. I looked it up a little bit, but couldn't find. Maybe if you have a private drug plan that has really good coverage, but even some of those good drug plans are excluding that medication off their formulary.
All right, perfect. I think that's it. Sam, back to you.
Great. All right. So to claim Main Pro Plus credits for today's webinar, please fill out our online survey. It's open until the end of the day on Friday, and the link is in the chat. So please feel free to go to the chat and click on that link. We also wanted to let you know that our webinar series is on hiatus for July and August. So we won't be back until September, but we have a great lineup ready for September. In the meantime, if you wanted to do some continuing professional development over the summer or any other time, we'd like to introduce you to CFPC Learn. It's the CFPC's new online learning platform with a wide range of Main Pro Plus learning activities. It's got videos, podcasts, articles. It's got a game board. CFPC Learn really does have something for every family doctor, so please feel free to check it out. The website is https://cfpclearn.ca. Feel free to check it out to learn more. Thanks for joining us. Have a fantastic summer, and we'll see you in the fall.